Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm speaking to Adrian Down. Adrian is the managing partner of a practice in Lincolnshire and a director of the Institute of General Practice Management, or IGPM. In this conversation, we discuss the vital role of the practice manager and the work the IGPM is doing to give managers a stronger voice and create clear standards through its accreditation scheme. Adrian talks about the challenges facing practice managers, including the risk of burnout, and what needs to happen to address these issues. We also look at the government's 10-year health plan and the move towards neighbourhood working, discussing what this will mean for practices and the pivotal role managers will play in making it a success. And we explore what the IGPM wants to see from the new GP contract to ensure it provides realistic funding and recognises the contribution of the entire general practice team, including the growing number of non-GP partners. Before we start, just a quick message from our colleagues on MIMS Learning. In-person learning is a vital part of keeping up to date, enabling GPs and other health professionals to learn with colleagues, ask questions of expert speakers and benefit from networking. MIMS Learning's event page gives you details of all the general practice focused learning events, which will provide you with practical take-home points for your practice, along with CPD certification. Visit mimslearning.co.uk/pages/events to find out more. I'm really pleased to welcome onto the podcast now Adrian Down, who is the managing partner of a practice in Lincolnshire and a director of the Institute of General Practice Management. As well as his role in his practice, Adrian serves as a director and committee member of his local LMC and is a founding director of a GP federation that represents 16 practices across his area. Thank you so much for coming on the podcast, Adrian.
It's a pleasure, Emma. Thank you for having me.
Let's start off with what the IGPM does. So you're one of 3 new directors at the Institute of General Practice Management. In case people don't know, what exactly does your organisation do?
In a nutshell, the IGPM is about giving practice managers a proper voice. For years, we've done one of the most complex jobs, I'd like to say, in the NHS, but without any particular recognition or support structure. And the IGPM is really here to change that. It's about the advocacy of standards, developments, and really not just being invisible anymore. I got involved with it because I'd spent years watching brilliant practice managers quietly getting on with their job. And I thought, if we don't stand up for ourselves, who will?
We're talking just in the wake of the 10-year health plan being published. It's quite an ambitious plan for the future. I mean, how do you see it impacting on GP practices in the coming years? What do you think some of the key changes practices will see as a result of this?
I think ambitious is a really good word. You've summed it up very well there. Ambitious, but potentially vague. So it's quite short on detail. For us in general practice, the next couple of years are going to bring a lot of focus onto neighbourhood working, an area that we're probably particularly good at already. It will bring collaboration and hopefully moving more services into primary care settings. Now that does sound great on paper, obviously good for patients, but it will only work if the funding and the workforce follow that plan. Without that, we're just going to stretch the same teams thinner and thinner across a bigger patch, and ultimately patient care will suffer.
Do you think it's all going to bring any specific changes for practice managers? What role do you think practice managers will have in a neighbourhood NHS?
I think practice managers will be key to making this work. We're central really to that neighbourhood working already, not just running our practices, but we coordinate between teams, we coordinate with providers. We could even be leading that neighbourhood delivery. But that comes with more responsibility and probably without the clarity or resource that we will need to do that. So I think, yes, the role will change, but we need to make sure it's supported and recognised properly.
Do you think that practice managers are going to have to take on greater leadership roles, for example? Is that what you see happening?
I can see that sort of model around leadership will certainly change. I think that when we're working together over a bigger scale, if that leadership isn't kind of built into that plan, if there isn't a design for how that works, then we'll be left with trying to work it out amongst ourselves, which we're generally very good at. And, as PMs, we do play nicely with each other. We do play very well together. But I think unless that detail goes in there, we will inevitably have to design it ourselves in a way that will work.
Practice management can be quite a lonely job in the sense in the practice you're in, and lots of practice managers I've come across, they often have very active local groups of practice managers where people network and support each other. That could be quite a good framework on which to build if you're trying to deliver a neighbourhood NHS.
From a personal point of view, I work really, really well with my local practices, and I've
Yeah.
been very lucky to have the colleagues I do working in our area. And I think, again, bringing it back to that IGPM discussion, it's one of the reasons I think the IGPM is so important for us, because it actually gives us a network of like-minded people doing a similar, not always the same, but similar job, working in the same industry, working with the same pressures, who can understand what our personal challenges are likely to be. So having an organisation that's there for us to turn to, ask questions that sometimes might feel like silly questions that we all ask. They generally aren't. They're just a question that you don't happen to have the answer to. And I think those networks are super important to the way that we work as practice managers.
One of the big things the IGPM been involved in since you launched is this idea of accreditation for practice managers. And there's been a lot of talk over the years about regulation for NHS managers. And there's been some stuff recently about regulation for very senior managers in hospitals. And the 10-year plan also has some mentions of a new management and leadership framework, which will include a code of practice standards and competencies for managers. It's not really clear whether this will apply to practice managers. What's your view on regulation for managers?
You're right. It isn't clear within the 10-year plan, but certainly the BMA have been pushing now for that regulation framework for management to include practice managers. They've made clear that that would include, in their view, that should include practice management. I think the idea of a framework or standard does make sense. We're managing public money, we're managing staff and patient care. It has to be meaningful. It can't just be another tick box exercise. If we apply it across the board, so it's not just secondary care managers, practice managers mustn't therefore be an afterthought. So the same structure is applied that would work with secondary care shouldn't then be applied to primary care and general practice, because we are a different organisation. And again, this is where an organisation like the IGPM and their accreditation process matters, because we've already set out really clear and fair standards for how practice managers do their job.
Why do you think accreditation is important?
It gives us recognition. It sets a benchmark. It says this is what a professional, competent practice manager looks like. It's about giving people confidence in the role of a manager. It gives confidence to partners in practices and for the wider system. I think it brings consistency. That is kind of really important from a patient and a system-wide basis. So the accreditation we've brought in, I think, covers all of those areas.
And how does it actually work? What does it actually involve? So practice managers who want to become accredited, what do they have to do?
So it's a portfolio-based process, largely reflecting upon the experiences and knowledge that you already have, how you meet the standard. It's very clearly not designed to trip people up. It's a supportive and developmental process. Is there a proper peer review angle to the way that it's designed? If you have gaps in your knowledge or gaps in your experience, you can then work on them. It's not a rubber stamp. It's a real assessment, and truly, truly means something when you pass it. I passed mine a year, 18 months or so ago, and it felt like a true achievement. It felt like something that, after 20 years of career, recognise what I've achieved.
The thing is that practice managers' roles are so important, aren't they? It really is. The difference between having a good practice manager and not is massively significant to practices, isn't it?
I think so. I think it's a pivotal leadership role in a practice. You describe people saying that it can be a lonely role, and it can. You're working in a position where sometimes you're reporting to a group of partners, you're representing staff, but you're also managing staff. Getting that right, having the right person in that job can absolutely be the glue that holds a practice together, I believe.
You've got quite an interesting role as well. I mentioned at the start, because you're also a committee member on your LMC, and you also helped set up your local GP Federation, which you're a director of. How did all of that come about?
I'm just a generally nosy person who doesn't like to think that other people are doing things. I don't know what's going on, really. That's probably it. But sometimes these things happen a bit by accident, don't they? You get involved in something. I think I like to know why decisions are being made. I like to understand the story of how we get to where we're going. That was why it was important to be involved in the early parts of the process for when decisions are made. And the more involved I got, actually, I realised how important it was that we speak up for practice management. With the Federation, it was about doing what we do really well, better, and doing it at some scale. It's important to keep things in general practice. And I truly believe we should be focusing on having work done by us rather than having things done to us by people who don't necessarily understand the full process of what we're doing.
The 10-year plan sort of suggests these two new contracts for neighbourhood working, one for neighbourhood providers and the other for multi-neighbourhood providers. How do you see them working? Do you think there's something that you'll be looking at in your local area?
We're always really forward thinking. So I'm really lucky with the people I work with. We've been working as a federation and effectively as a neighbourhood for some time, and it works really, really well for us. I think joining up care locally and working at scale often makes sense, although individual small practices can provide outstanding care to patients. But the devil will always be in the detail of how this happens. You can add complexity and not add improvement in care. If it comes with proper resources to do the job properly, it offers support but autonomy as well, then I think it could be a good thing. If not, I think it's just another restructuring and has the danger of just being a lot more meetings that don't impact well onto patients.
What are you doing in terms of neighbourhood working in your area then? What benefits have you seen from this sort of approach?
We've been working as a neighbourhood team now for several years. And in fact, we've had visitors from the Department of Health out to our area to see how we're working. We work in a very multidisciplinary way. We have care coordinators who specifically are looking after our most frail and vulnerable patients, and they link together. So, for example, covering annual leave, they work together where they have particular skill sets, so they can sort of bounce ideas off of each other. And as a neighbourhood, that's worked really well for us, and it's meant that some of the things that we can bring in at scale for patients where it may be either too complex or we're just not resourced well enough to do in one particular practice. And we've done that all through our federation, and we've done that with support of our local ICB, who were very forward thinking about the idea of neighbourhoods. So I would like to hope that some of the work that we've done has formed this picture of where neighbourhood working can be a really positive step forward.
You touched on there about the federations and that scale. I mean, do you think that they've got a pretty important role in this new way of working?
So what's been great about our federation is that ultimately we chose the people who we wanted to work with. And that's not to say that we didn't want to work with other people, but we found the scale of where it happens. So we're based around two small market towns, but between those two small market towns, we share one relatively small hospital, but it means that a lot of our care heads that way. So the federation for us works so well because it was what we wanted and where we wanted it to be. It was a chosen one. And I think we're kind of the glue in between our local practices. And it gives us that opportunity to deliver at scale. We can share risks. We can give practices breathing room when they need it. But only has worked so well because we made it GP-led as well as practice manager shaped, and I feel been a huge success.
That is interesting because if people got ownership of it, they're much more likely to invest their time and effort into making it a success, aren't they?
You feel part of the process, and you feel that you're involved in the decision rather than you're having something done to you. And done with you is always better than done to you.
What do you think practices should be doing now to sort of prepare themselves for all of this? It sounds like you're kind of a bit further along. I was talking to someone the other day and they said it was really important that practices make sure they know what's happening in their local area, because you don't want to miss out on any opportunities, but you don't want to get left behind either.
I mean, the one bit of advice I would give probably ties in with what we've just been speaking about, that don't try and go it alone. Find your tribe. What's your kind of natural geography? What's your natural shared ethos? Find the other practices that you could work with to form that neighbourhood, so that you're doing it through choice. You're doing it to really give benefit to your practice, to give benefit to your patients, rather than, well, we're being forced into this, so we're going to have to work with those people. Now, if you can get that structure built for yourselves, then it will make the whole process so much easier.
Obviously, the other big thing coming down the track is a new GP contract. What does the IGPM want to see from a new GP contract? I know that you meet with the BMA GP committee. What are you hoping will come out of these contract negotiations? It
does say that, or we were told that there would be a new GP contract in this Parliament. And I guess the clock is probably ticking. We're down to that happening within the next 3 or so years. And these things don't tend to happen that quickly, I would think. From an IGPM point of view and a personal point of view, is recognition for the whole team. The phrase GP has gone from being a specific person to being a general practice team. And we need to ensure there's realistic funding and resourcing for what a practice now actually does. The numbers get bandied around quite a lot, but I'm pretty sure that there's a number somewhere above 90% of all interaction in the NHS happens in general practice every day. And we do that with less than 7% of the overall budget. So to actually be able to resource our bit of the pie appropriately so that we can get on with it, I think is key to this. I think less micromanagement potentially. Something about non-GP partners. There's a growing number of us, be that practice managers, pharmacists, nurses. There's a growing number of non-GP partners. We are helping to run and manage that practice, but we don't have any voice in the contract negotiations, which ultimately will only be with the GPC, which is a committee of the BMA, which is the doctors' union. So what we would like to see is representation from other partners in practice during those negotiations.
So if someone didn't really understand what a practice manager's role is, how would you describe it? What would you say their key job is?
A really big part of it is we need to remain and look calm when all isn't calm. We are the people that generally within a practice, everybody will look to for the answer. We're part business manager, part HR manager, part operations manager. Sometimes we're a therapist to our colleagues. You're running a small NHS organisation and you can serve tens of thousands of people with that role. And we're managing a team, we're meeting targets, we're keeping the place to standards. And then we still have time to deal with Mr. Jones' complaint about the car park. It's a demanding and complicated job, but it's also the most rewarding job that I've ever had.
What skills do practice managers need today? Practices are so different, aren't they?
I think you need to be a competent manager of people. You need to be able to understand the people you're working with. I believe overall that the most important thing I can do is find the very best people to do the jobs that they need to do. Most of my colleagues are doing jobs that I cannot do. So GPs, nurses, pharmacists, dispensers, I cannot do their job. Our reception team are astonishingly good. You know, the job that they do, care they give to patients, the customer service. I've tried doing that and I'm a woeful failure when it comes to sitting on reception. But I think the one thing that I do well, and I think a lot of my colleagues do really well, is they find the right people to do these jobs. If you can find good colleagues and you can surround yourself with the people who will do the job well, then your organisation will succeed. I can probably bottle it up into that one. Just make sure you surround yourself with people who are way better than you. And I'm very, very good at that.
I'm sure they're not way better than you. You sound like you're pretty good at what you do as well. I mentioned at the start as well, you're the managing partner of your practice. You know, we've talked about this, you're a partner. How does that change your role as a practice manager when you become a partner? What kind of extra responsibilities do you have now?
I was always very lucky. When I joined the practice I work at, where I've been here for 20 years, the partnership were brilliant. They always involved me in decisions. Probably coming to the end of the answer first, it hasn't in many ways changed my role. I'm probably more involved in strategy, long-term planning and partnership decisions, but it's quite a blurred line because, as I say, I was involved in that as normal. I'm still doing the same day-to-day job. That responsibility hasn't changed. I think there's more risk because I take on a personal risk now by being a partner. I have unlimited liability, the same as my GP colleagues. I suppose also more ownership. Having that chance to shape the future of our practice and hopefully change it for when I leave, when I retire, having the chance to leave some sort of legacy for the long-term strength of our organisation is probably, for me, the change, but it's pretty subtle. I think for many practice managers who become partners, it's more an extension of what they're already doing and potentially a recognition of their place in that organisation.
You've got quite an interesting background as well. I mean, you say you've been in your practice for 20 years, but you came to general practice from outside the NHS. What were you doing before and why did you decide to become a practice manager?
I worked in industry prior to this, had a very good job, worked with people that I really enjoyed working with. They gave me a nice car and I used to get to travel quite a lot. But I also had a young family, and it was really important to me that I was involved in bringing up my children. I was involved in that kind of home life. So the partnership that I came into were a very, very family focused organization. And so one of the things that really appealed to me was that it meant that I could drop my children off at school. And that was incredibly important. It was incredibly frustrating. I don't know if you drop children off at school, but it can be one of the most frustrating jobs that any of us have. But so important. And so for me, that was a part of the decision. But also, even though the industry I was involved with was very important, I kind of felt that if I didn't turn up at work one day, it wouldn't have a massive impact on the lives of people. Whereas as a practice manager and the type of organization we are, if any one bit of it were to kind of go missing and not work, it would be more important than widgets. It would be about people. It would be about the care that we provide. So I wanted to be involved in something that truly made a difference in people's lives.
There's lots of people who are practice managers who sort of work their way up to that position through the practice, but there's obviously people like yourself who come from outside the NHS. Do you have a sense on whether the number of people coming into practice management from outside the NHS is increasing? Do more of them have experiences from elsewhere, and has that changed?
I think looking locally, it probably has. I absolutely hold my hat off to anybody coming into this from outside now, though. I can remember 20 years ago, basically I was shown the job over a couple of weeks, and I was told this is the spreadsheet that you send in quarterly to I think at the time it was PCT. Once a year you'll trundle off with a box of quaff work to hand over to the lovely chap at the PCT. And I think in my first year I had something like 600 emails in the first year, whereas probably at least that a week now. So the change of job, the complexity, the things that have come into it, the reporting, the structuring, the number of passwords you have to remember, literally the complexity of the job is what's changed most. And I'm lucky because I grew up with most of that change, whereas for anybody coming in, I think it is just astonishing that they can pick it up and do the job.
What do you think some of the key challenges facing practice managers at the moment are? Is it to do with that complexity, or are there other things as well?
For all the positives of our job, for all the things that make it so fulfilling, I worry with some colleagues when you see the pressure they're put under and the pressure they sometimes put themselves under. I worry about that burnout, managing a workforce, that constant change, the unrealistic expectations that can be put on people. We're often doing more with less. Unfortunately, that can be with little support. I speak about having been and being in a great partnership where I have partners who care about me, care about what I do, care about my well-being, care about colleagues. That doesn't happen everywhere. It's really hard to lead when you're firefighting all the time. And recruitment can become a real issue for both practices and practice managers. So I think recruitment is certainly a key issue, but I also think ensuring that we're looking after the people who are doing the job is super important.
We write a lot about burnout amongst GPs. Is it a really big problem for practice managers as well? I can imagine it must be.
I think often practice managers, being the type of people they are, being the sort of people who will, again, always try to look calm no matter what's going on, can often lead to them hiding that pressure because they feel that everyone should turn to them to be the person that's coping. Yes, it can be. And I have seen, sadly, this happen to people who are great at their job, but just haven't got a mechanism to go anywhere. That's either led to them leaving their job or becoming unwell and not being able to work. It is a real problem. More and more work will often find its way into practice management. And as I say, we're people who cope. We will take anything on. We will always try to fix whatever's thrown at us. But we are probably not that great at looking after ourselves compared to looking after others.
What do you think needs to happen to address this? Is it about funding? Is it about having a better GP contract that actually pays practices appropriately for what they do? Is that the key to solving some of these challenges?
That would be a great start. I think recognition at a national level for practice management would be great. It's not just a job it falls into. We need investment in time, training and resources to train people to do the jobs we do. We need the people who are making decisions to actually listen to the people who are doing the work. We were very fortunate as an IGPM group of directors to be invited to Parliament by MPs from both the Health Select Committee and otherwise, who we had the opportunity to explain to them the role that we do in practice management, the role of the IGPM in that, and the challenges that face us. And actually, that was quite gratifying. It was very supportive. The MPs we spoke with really seemed to listen to what we came to them with. And hopefully that's the start of something. That's the start of our voice being heard. Because I think to address these challenges, we need to be involved in helping them to make the service the best it can possibly be.
That's the really good thing about having an organisation like the IGPM, is that you can go to, hopefully, push on more doors and get your views in front of people like those MPs, or even like the BMA, have more of a relationship with them to give your point of view about how you want the contract to change.
Our ethos is very much that we want to work with other bodies. We feel that we're stronger together. We're stronger working alongside organisations like the BMA and GPC. We would say we want to be beside you, not behind you. We want to be at the table. We want to be supporting you, working alongside you, but I say not in the background. We want to be in the foreground of this decision-making process.
You work in quite a rural area, and we've talked a little bit about neighbourhood working, and you've sort of explained how it works in your area. I mean, how big is your sort of neighbourhood footprint? Are you sort of smaller or bigger than the average they're talking about?
So we are with we're one federation with two PCNs working within that federation, and we cover about 137,000 patients overall. So geographically, we cover a pretty vast footprint. Yeah. It could take 3/4 of an hour to an hour to travel from one end of our geography to the other. And within that, we have people like paramedics working who are first contact, and they're covering that area. So there's a lot of clever work done by clever people in the background who work out how we can make that work and cover the footprint. So distance for rural communities is difficult. Part of the 10-year plan talks about neighbourhood hubs. I don't know where a neighbourhood hub would sit in our geography, where it would actually be better for patients. And actually, we've kind of got neighbourhood hubs because that's called a GP practice. That's where our patients turn to for the sort of support that's listed. We have, working from my practice and my local practices, we have first contact physiotherapists, we have pharmacists, we have a wide variety of skill sets that are kind of designed within this neighbourhood plan, but they're already here. Our challenge is often that we've run out of space. We physically can't fit more bodies into the buildings we've got. But I would urge there to be the possibility for funding the existing resource rather than trying to make a new central hub. Yeah. I think that's quite important. The 10-year plan will hopefully bring investment, but often in previous investments, that has tended to ignore rurality. It's tended to ignore the challenges that come with rurality, the deprivation that can come from rurality. In our county, we have some of the most deprived coastal areas in the country. And the challenge that brings, the complexity of healthcare that can bring, can't be ignored. So I think there can be real benefit to patients from joined up thinking and bringing care closer to home. For some of our patients, again, traveling to a hospital isn't an easy process. Getting there can involve, a frail older person living in our community who no longer drives. It isn't just a case of getting on a bus, because there might only be one bus or no bus. They can't necessarily get onto a train. So even for some of our patients, getting to the surgery can be a £20 or £30 taxi drive. So getting into a hospital can be a decision that some people have to put that transport against their ability to heat their house that week. It's literally that important. So more joined up care, closer to home, but it's our job to fight to make sure that happens. And as an IGPM, as practice managers, as general practice, that's one thing that I think we're going to be pretty good at.
If you don't live in a rural area, you don't really necessarily think about these sorts of things, because it's not just like people getting to hospital as well. It's also being able to have their family come and visit them.
And people often move into those rural communities when they are young, vibrant, healthy people who have transport, who can look after themselves very well, for people to maintain that dignity of staying in their own home, of staying in the place that's been where they've brought up their families, where they've lived with loved ones, can then again be a really difficult decision when you're living in a remote rural location, and something as simple as losing the ability to drive your car can have a huge impact on the well-being of that person. And suddenly they can go from being somebody who goes along to clubs, societies, visits the shop, goes out to the hairdresser, can go to them being somebody who is truly trapped in their home because they can't get out into those communities. So I think recognizing rurality and the challenge of providing healthcare in rurality, we still visit a lot of our patients in their own homes, and it's a privilege that they invite us in. But obviously, taking a GP who has a 10 or 15-minute consultation with a patient they see in a surgery, a home visit can easily be an hour, where 40 minutes of that are travelling to and from the patient's home. So I think the challenge of rurality is not to be underestimated.
That's brilliant. Thank you very much for coming on the podcast today, Adrian.
Thank you, Emma. It was a pleasure.
Well, that's it for this week. Thanks again to Adrian, and thank you for listening. If you're enjoying Talking General Practice, please do think about leaving us a review on your podcast platform. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget, you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.